So, very good afternoon. We're talking on nutrition in the critically ill today. Before we start, you have to understand how normally the nutrition works. So, what happens? So, in conditions where you have good amount of substrate availability in the form of carbohydrates, in the form of proteins. So what happens is that with the intake of glucose, there's an increase in insulin, and a decrease in glucagon. That means this is what is studied as the insulin-glucagon ratio. So what happens with this hormonal milieu? You have glycogenesis, you have lipogenesis, and you have increased protein synthesis and a decreased catabolism. So normally, your body functions in an anabolic state. So this is how that happens. So what happens during starvation? Now, during starvation, this ratio that we were talking about, the insulin-glucagon ratio, it reverses. So what do you have now? An increase in glucagon with a decrease in insulin. Now, what happens? What happens is that there is a reduction in glycogenolysis and an increase in lipolysis. So what happens in this catabolic stage during starvation? Due to this increased lipolysis, fat is metabolized. There's a decrease in synthesis of protein and an increase in catabolism. And hence, this protein is also used for glucose synthesis. So everything, whether it's your proteins, whether it's your fat, they are preferentially shuttled for glucose synthesis in the presence of an increased glucagon and insulin ratio. This means what will happen is that due to the increase in this counter-regulatory hormones, there is decreased protein synthesis and an increased protein breakdown and increased fat breakdown. So what do we do in this condition? So the first thing that we need to learn is how you assess your patient regarding their nutritional status. So nutritional assessment in the acutely ill, so there are a number of scores. So why have these scores been developed? These scores have been developed so that people like you and I, we have something to objectively assess our patient. So it's not enough to say that this patient is thin, this patient is fat. Even obese patients may be very, very nutritionally poor. So that is why you have this score, which is known as the NUTRIC score. The NUTRIC score is recommended for risk stratification in the critically ill patients. It is available both with and without the interleukin-6 because it is mostly very, very difficult for us to do an interleukin-6. Now, one thing if you notice, if you look at these variables, the age, the Apache, the SOFA, the number of comorbidities, and the days from hospital to ICU admission, you will understand that this nutritional assessment, the major variables, all of them here are basically the severity of the illness and how long the patient has been admitted. So it has nothing to do with the baseline BMI. It has nothing to do with the albumin levels. It has nothing to do with whether or not you have a good triceps thickness at your forearm or your arm. All it tells you is that if your patient is very sick and has been in the hospital for a long time, your patient has a much, much higher nutritional risk than someone else. So that is what the NUTRIC score tells you. It was introduced in critical care in 2011. So just considering the patient that we had just discussed, you'll find that the NUTRIC score for this patient came to be 7. So what was this patient? I'll go back. He was a 78-year-old gentleman who was shifted from another ICU after a stay of around 2 days He has had a recent MI, he is diabetic and a previous ischemic stroke. His SOFA is 8 and his Apache is 22. When you get all these variables and you calculate the score, the Nutric score will come out to be 7. So now we come to the question as regarding this patient, this Nutric, and you can see here that a 5 to 9 is a high risk, even if it is done without an IL-6. So now you have a high risk patient, a patient who has a high nutritional risk, and you want to know how much you want to feed this patient. So regarding caloric requirements. So caloric requirements ideally should be calculated by an indirect calorimetry. It is the standard, it is the gold standard, right? And what happens there? It actually measures your CO2 production and your oxygen consumption and tells you how much is the caloric requirement of your body. However, you must know very well. So what you need to understand is that indirect calorimetry is your gold standard and you need to remember that. So many people have actually tried to come up with alternatives. They've tried to integrate modules for indirect caloric requirement assessment, and these modules have been incorporated into ventilators. However, most of us, what we do is we use the predictive equations, right? So what are the predictive equations? They are, you have things like Harris-Benedict equation, you have the things like Ireton-Jones equation, but you need to understand that all these predictive equations, they vary in performance depending on the subgroup, the patient subtype that you are studying. And a lot of them have very little validity in critical illness specific situations. So what people actually came up with is that you simplify it. You want to give 25 to 30 kilocalorie per kg per day. That is all you need for practical purposes. That is all you need to remember at this moment. So 25 to 30 kilocalorie per kg per day, because it has been seen that irrespective of these equations, it kind of matches with this 25 to 30 kilocalorie per day. So this is now recommended even in your guidelines. So what happens during overfeeding? So during overfeeding, suppose you have carbohydrate overfeeding, you will go in obviously for hyperglycemia, you will have excess carbon dioxide production, electrolyte disorders. You can have, in case you suddenly increase your the calories, number of calories you are providing, you can go into refeeding syndrome, you can go into things like hepatic steatosis. So these are all consequences of overfeeding. And of course, you can also look like that dog. And you can also have things like hypertriglyceridemia, immune dysfunction, and azotemia. So these are important to understand that overfeeding, even for a critically ill patient, may not be good. So what happens is, hello? Excuse me? So what about underfeeding? So the question was put in, is hypocaloric feeding actually bad? So that is how, what they did is that they studied animal model patients. So they actually simulated peritonitis in guinea pigs, and they found that if you look at the survival, underfed people, right, that is underfed rats, they actually had more survival than your normal or definitely your overfeed, right? And there was no deleterious effects on gut function, and there was benefit to the immune, cardiac, and renal functions. So this made people wonder that should we at all go for overfeeding or even normal feeding? Why don't we go for underfeeding? However, when all these studies, they were replicated in human beings, we haven't been able to find an answer that underfeeding is definitely beneficial. So well, there is a theory that underfeeding may be beneficial, and there have been trials, you have trials like the Eden trial now that says that even if you do hypocaloric feeding for the first 7 days in ARDS patient, it makes no difference. However, in the absence of proper randomized controlled trial and large-scale studies, we have not been able to put it up as a standard of care. So now, till now, what have we understood? We have understood how the normal physiology is, what happens during starvation, how much calories you're supposed to give, and what are the consequences of overfeeding and underfeeding. We have also considered our particular patient who we have classified on the basis of Nutric score to have a high risk, a nutritional risk, and we are in fact now trying to decide how much we want to feed this patient. So now for our patient, so we have now guidelines which have come up, and they say that whenever you start feeding, you shouldn't start with 100% of the targeted requirement on day 1, right? So for day 1, it could be around 25%, which should be gradually escalated to 50, day 375, and that is how you go. In short, what you should do is that you should progressively increase the amount of calories. This will not only give you this will not only help you to prevent overfeeding, but it will also help for patient tolerance. So if you remember that patient, so for this patient, the first day we were not able to feed him. On day 2, we gave him around 500, and on day 3, around 900 kilocalories. So that was the patient. And now we go on to discuss what exactly should we feed. So we have learned how to classify, how much, so what. Carbohydrate requirements. Now, you need to understand that there is a lot of insulin resistance in ICU patients. Hence, utilization of carbohydrates is often limited. So the maximal utilization is a ballpark figure around 5 milligram per kg, which can be said is that you can give around 800 to 1200 kilocalories as glucose. That is 50 to 80% of your caloric intake can be in the form of carbohydrates. You definitely need to monitor for hyperglycemia.